My topic for today is Cryptorchidism, and as you all know that Cryptorchidism is something that not only a pediatric surgeon deals with, but also you as general surgeons will also be dealing with children with Cryptorchidism in some way or the other. So I'd like to revise some of the things that you probably already know, because this is quite a very popular topic that you have been taught in MBBS as well. So there's nothing new to add, but we'll try to revise it and make it a complete, comprehensive topic. So our learning objective for today will be to discuss the embryology and the mechanism of testicular descent. We'll talk about the clinical presentations, the problems of an undescended testis, how to work up for a case of undescended testis, what are the management strategies, and what are the outcomes and complications of surgery. So as you all know that crypto is hidden and orchis is testis. So it means that there is an absence of testis in the scrotum. But this always does not mean an undescended testis. By the end of this class you will know that cryptorchidism and undescended testis are not synonyms. So talking about the embryology, you all know that the gonads, they develop at the genital ridge besides the mesonephric kidneys. They both develop together and then one ascends and the other descends down. So by 6 weeks, the gonad, the undifferentiated gonad, it differentiates into the testis under the influence of the SRY gene. And the Mullerian inhibiting factor that produced by the Sertoli cells, they cause regression of the Mullerian duct structures. And by week 9, the Leydig cells, they start to produce testosterone that stimulate the development of the Wolffian structures, which are the predominantly male structures. By week 12, the testis that is now differentiated, it resides in the abdomen near the internal ring until the descent begins. And the descent begins at about 7 to 9 months. Through the 7 to 9 months, it traverses the inguinal canal and it reaches the bottom of the scrotum, sometimes shortly before birth and sometimes in some babies shortly after birth. So the testicular descent will have 3 phases. First is the transabdominal migration of the testis to the internal ring, then the development of the processus vaginalis and the inguinal canal, and then the transinguinal descent through the inguinal canal into the scrotum. So what are the factors that cause testicular descent? You all know that the most important factor for testicular descent is the mechanical and anatomical factors. So the most important feature is the intra-abdominal pressure. That is the pressure that drives the part of the peritoneum into the developing internal ring so that it forms the processus vaginalis, right? And that processus vaginalis, it transmits the pressure, intra-abdominal pressure into the inguinal canal at the tip of the gubernaculum testis, and that starts the descent. So one of the important factors is gubernaculum testis, but we all have one small misconception about the gubernaculum testis, is that it is the traction of the gubernaculum that causes descent, but it is not true. Nowadays it has been shown that actually gubernaculum testis is not attached either to the testis or to the scrotum. So how can it cause any traction? It doesn't cause traction, it only guides the testis into the scrotum. So there are 2 developmental phases of the gubernaculum testis. One is the outgrowth, in which the gubernaculum, there is rapid swelling of the gubernaculum, and that dilates the inguinal canal and makes it ready for the testicular descent. And the other part is regression. In this phase, the gubernaculum undergoes remodeling, and then it becomes a fibrous structure that is rich in collagen and elastin. And it, as I just said, it is not anchored to the scrotum, and it doesn't provide any traction for descent. So the other important factors are hormonal factors, among which androgen and androgen receptors are important, because it has been shown that frequency of undescended testis is more in boys with diseases that hamper the androgen synthesis. Then there is Mullerian inhibiting factors, because without resorption of the Mullerian structures, there is always an anatomical impedance to descent. And then there are insulin-like factor 3 anise receptor, calcitonin gene-related peptide, and epidermal growth factors. These are also important factors, hormonal factors for testicular descent. So an undescended testis or a cryptorchid testis is most commonly associated with several conditions like Tourne-Bailey syndrome and abdominal wall defects. Like I said, because intra-abdominal pressure is a very important driving force that causes descent, any defect that causes loss of intra-abdominal pressure will have associated undescended testis. One of them is poor belly syndrome. Because the abdominal muscles are weak and then there is less intra-abdominal pressure, it cannot drive the testis into the inguinal canal. And other abdominal wall defects like gastroschisis, omphalocele, and sometimes a large umbilical hernia also. So what are the clinical presentations of a cryptorchid testis? As you all know, the cryptorchid testis means there is absence of testis in the scrotum. That is the first clinical picture of a cryptorchid testis. But as I said, there are various types of it. Cryptorchid testis is not only undescended. There are several other varieties as well. So one of them can be an ectopic testis. So an undescended testis or a true undescended testis, it is a testis that is arrested along the line of descent. It is inside the line of descent of the testis. But an ectopic testis is a testis that has deviated from the line of descent. And the possible locations can be at the root of the penis, at the femoral canal, at the perineum, or maybe even in the contralateral hemiscrotum. So that means it has deviated outside. You won't find a testis in the ipsilateral hemiscrotum, but then it can be somewhere else. And then there is another clinical entity in which there is a palpable versus non-palpable testis. So a palpable testis is an undescended testis which lies along the inguinal canal, because that is the reason of the testicular descent that we can actually palpate. And even a palpable testis can be a retractile testis or also an ectopic testis. And a non-palpable testis can be an intra-abdominal undescended testis or a vanishing testis or testicular agenesis. There might be no testis at all. So talking about retractile versus acquired undescended testis, a retractile testis is a normally descended testis that retracts into the inguinal canal due to cremasteric contraction. And this testis can be manipulated down into the scrotum and with very little traction, and then it will stay there once you release your traction. But an acquired undescended testis, it was a normally descended testis. Testis was present in the scrotum at some time previously, but now it can no longer be brought down into the scrotum. That is an acquired undescended testis. It is usually a complication of inguinal surgery due to scarring proximal to the scrotum. So the histopathological hallmarks, they are evident between 1 to 2 years of age. Before that, you won't see any histopathological hallmarks. So the histopathological hallmarks will be decreased number of Leydig cells, degeneration of Sertoli cells, delayed appearance of adult spermatogonia, failure of primary spermatocytes to develop, and reduced total germ cell count. That is why it is so important to perform orchidopexy before a certain age, because those testes that stay inside the abdomen, they lose their capacity for fertility. So how do we work up for an undescended testis? So the history is always important, because we want to know whether it is an acquired or retractile testis or a true undescended testis. So the first question would be whether the testis was ever present in the scrotum any time before this visit. Because if it was ever present, then it might be a retractile testis or a secondary undescended testis, right? And retractile testis, you will find that retractile testis is not present before about 2 years of age, because before 2 years of age the cremasteric reflex is very weak, and so it cannot pull the testis into the inguinal canal. So examination, the prerequisite would be a warm room is required, because as you all know that if cold will cause shrinkage and increase cremasteric reflex, and the testis will come up. And a lubrication in the examination finger is important. And the position we examine in two positions. One is a supine position, and the other is a frog-legged sitting position. So first is inspection. We inspect the scrotal development. A true undescended testis will have scrotal hypoplasia. You will find that the scrotum is flat, there is loss of rugosity. So that signifies actually that the testis has never descended into the scrotum. And then the next step is palpation. So the palpation is, first you have to give a very gentle abdominal pressure, so that anything that is something called a peeping testis, that is just that resides just below the internal ring, that can be pushed into the internal ring. And then you can use the finger of the non-dominant hand to occlude the internal ring, and then use your examining hand, lubricated examining hand, to slide it along the inguinal canal to the scrotum and to palpate the testis. And it has been shown that a very experienced surgeon's clinical examination is more accurate than an ultrasound examination actually. But you will find that both retractile testis and a low undescended testis can be brought into the scrotum. But how to differentiate that? Retractile testis, as I said, if you leave it, it will stay in place. But a low undescended testis will again rise back into the inguinal canal. So imaging, there is no added value if the testis is palpable. There is no added value. But if it is not palpable, then it can provide some added advantage. And ultrasonography, it has a very low negative predictive value. It cannot say that the testis is absent. If it finds a testis, it is okay. But if it doesn't find, then you can't say that the testis is absent. That is the problem of ultrasonography. So MRI is favored obviously, and the MRI sensitivity can be increased by adding gadolinium, because in MRA, testis is very bright. And nowadays, the laparoscopy, it has a more than 95% sensitivity for locating a testis as well as saying that it is absent. So that is why nowadays whenever there is a non-palpable testis or you cannot find a testis, laparoscopy is the procedure of choice. So what are the problems in an undescended testis? The first problem is infertility, because the undescended testis is histologically abnormal and the epididymis is also abnormal. That is why. Number 2 is risk of malignancy, as you all know. So the risk of malignancy is 5 to 60 times. Some series have shown up to 60 times increased risk than general population in a cryptorchid testis. And the most commonly associated tumor in an uncorrected undescended testis is seminoma, and a corrected testis is non-seminomatous lesions. There is risk of torsion because there is a relatively longer mesochium. And you all know that inguinal hernia is present almost in all cases of undescended testis. All cases of undescended testis, nearly all cases of undescended testis will have associated inguinal hernias. So now we're talking about the management strategies. So what are the indications of surgery? So the number 1 indication is early scrotal placement reduces infertility, but it does not reduce the risk of malignancy. It reduces the risk of torsion. It facilitates the examination of the testis. That is why it needs to be put into the scrotum. And it improves the endocrine function of the testis, and it creates a normal looking scrotum. So the timing of surgery, the recommended age of surgery or orchidopexy is at or near 1 year of age. Because spontaneous descent, it is unlikely after 9 to 12 months of age. And sometimes earlier repair can be attempted if there is a symptomatic inguinal hernia, because you all know that there is inguinal hernia associated. So if there is a symptomatic hernia, sometimes we repair even before 1 year of age. So the orchidopexy is the surgery whenever possible in prepubertal boys, and sometimes orchidectomy is done, that is reserved for special cases. Such cases are post-pubertal males with contralateral normally descended testis, a cryptorchid testis that is anatomically or morphologically abnormal, and if the testis is too far from the scrotum to allow tension-free placement without vascular compromise. So in the treatment strategies, previously the hormonal treatment was practiced. Even nowadays it is practiced, especially in Europe. But it has a controversial value. People they give GnRH agonist, that is a buserelin, and up to success rate of up to 60% have been reported. But those success rates have been mostly for low or low undescended testis. But even then 60% will eventually again require surgery. Sometimes we give low dose HCG and low dose human gonadotropin. It restores the normal endocrine milieu and it enhances the germ cell maturation. It does not replace surgery as the treatment, but it can be used as an adjunct before surgery. And because it makes the testicular localization very easy, because it temporarily increases the size of the testis. The surgical treatment, it depends upon whether the testis is palpable or non-palpable, and unilateral and bilateral palpable testis are approached in the same way, and it is important to re-examine the child after induction of anesthesia, because oftentimes we see that previously non-palpable testis, it becomes palpable once the child is anesthetized. So you can now change the mode of operation. So for a palpable undescended testis, the standard treatment is orchidopexy with creation of a subdartos pouch, and scrotal fixation is achieved by scarring of the everted tunica vaginalis. So there are two approaches. The standard approach is a 2-incision inguinal approach. One is the inguinal incision and the other is a scrotal incision, and a single incision high scrotal approach. Both have their own advocates. So this talking about the standard orchidopexy, it's a day surgery under general anesthesia and caudal analgesia or ilioinguinal iliohypogastric nerve block. It provides excellent post-operative analgesia, and the incision is placed at the lower inguinal skin crease. So the key steps would be to locate the testis and deliver it outside the inguinal canal by freeing the gubernacular attachment. Then the tunica vaginalis is dissected away from the vas and the vessels. Then we ligate the proximal sac, doubly ligated, and then amputate the sac. Then we proceed for retroperitoneal dissection through the internal ring to provide additional cord length. This is called a Prentice maneuver because you all know that the hypotenuse is the shortest arm of a triangle, right? So we don't want the testis to go in through the two sides of a triangle. We follow the hypotenuse. So when you do that, you gain extra about 1 to 2 centimeters of length of the cord. So the tunnel is created from the inguinal canal to the scrotum using a finger, and the scrotal incision is made and a subdartus pouch is created, and the testis is guided into the tunnel, into the scrotum, and we're taking care not to twist the cord structures during the process. And then we narrow the neck of the dartus pouch and close the scrotal incision as well as the inguinal incision, and application of a waterproof dressing. So after that we follow up in 1 week for a wound check, and after several months, most commonly it is done at 3 months to see the final position and the size and consistency of the testis that we have just texted. So what do you do with a unilateral non-palpable testis? A combination of laparoscopy and inguinal exploration is applied. In laparoscopy, you might have 3 scenarios. One is you might find an intra-abdominal testis. The other is you might find that the testicular vessel is seen exiting through the internal ring, right? And if that is the case, then we proceed with inguinal exploration, because we know that the testis is inside the inguinal region. So it can be an intracanalic testis or an atrophic testis, we don't know. And then the vessels that might be blindly ending above the inguinal ring, that is a case of vanishing testis. Nothing needs to be done after that. So when it is an intra-abdominal testis, you know that the cord length is not going to be adequate to place it into the scrotum. So in that case, we do 2-stage procedure that is called a Fowler-Stephens orchidopexy. It is especially reserved for high undescended testis. The 2 stages are placed about 6 months apart. In this process, in this procedure, we do is we clip the ipsilateral testicular artery, and then we rely on the collateral vessels coming from the artery to the vas and the cremasteric artery to supply the testis, and then we mobilize the testis en bloc in the second stage and place it in the scrotum. But it is not suitable once inguinal exploration has been done, because the collateral blood supply are already lost. So that is for the high undescended testis. Now the problem arises when there is a bilateral non-palpable testis, because you don't know whether it is a cryptorchid testis or it is absent. You don't know. So first thing you have to make sure is whether there is testicular tissue inside the body or not. So for that we do an HCG stimulation test. We take a baseline testosterone, follicle stimulating hormone and luteinizing hormone level on day 0. Then we give 3 consecutive days of 2000 IU of beta HCG, and then we finally see the testosterone level on day 6. So the interpretation would be, if there is a high baseline FSH and LH in a boy more than 9 years of age, it means that testicular tissue is not there. It is a case of anorchia, so you don't need to do anything further. But if there is normal FSH and LH level and there is appropriate rise of testosterone after induction, then it means that there is testicular tissue somewhere in the body and you need to find where it is. So we apply laparoscopy or laparotomy for that procedure. And the other standard treatment would be microvascular autotransplantation. The indications are the same for Fowler-Stephens orchidopexy, and but the indications must be weighed in light of the circumstances of the clinical findings, because this is a very, very, very delicate operation and a very high degree of expertise is required. So if you summarize the surgical approaches for unilateral palpable testis, a dartos pouch orchidopexy would be adequate. For a unilateral non-palpable testis, laparoscopy is usually done. So three scenarios as I talked: blind ending vessels, intra-abdominal testis, and vessels exiting the internal ring. So if it is a blind ending vessels, no further things to be done. If it is an intra-abdominal testis, you can do a stage orchidopexy, if you can do a standard orchidopexy, or if the testis does not look good, then you can do an orchidectomy. So if the vessels are exiting outside the internal ring, you have to do an inguinal exploration and do the appropriate management. For a bilateral non-palpable testis, you have to do a baseline gonadotrophin. If it is increased, you have to suspect anorchia, and nothing needs to be done. If it is a normal baseline FSH, then SCG stimulation test, increased testosterone. If no response, even if there is no response, a laparoscopy and exploration is required. So the other entity is an acquired undescended testis. It is a common complication after inguinal surgery, in which we do an en bloc mobilization of the entire cord with a strip of external oblique aponeurysm, because this is the place where it is most commonly adherent, and we don't want to dissect it off that because the vascular compromise will be there. So to reduce that, we dissect the external oblique along with it and then put it into the scrotum. So the complications of an undescended surgery would be testicular retraction. This is one of the most common complications of undescended testis surgery. The hematoma formation is the other. Ilioinguinal nerve injury, damage to the vas deferens. This is the thing that patients are most dreaded about. And then the most dreadful complication would be testicular atrophy. Okay, thank you. If there are any questions, please.
Thank you so much, Dr. Manish, for a very comprehensive.
Non-palpable testis. What orchidopexy allows you to do is it allows you to examine the testis and discover a malignancy when it arises. So it doesn't reduce the incidence of the risk of malignancy. But of course, the risk of malignancy is proportionately higher in testis that is higher up in the ladder of descent. Because if it is an intra-abdominal testis, the malignancy rate is higher. If it is an inguinal testis, it is slightly lower. So because we all know that one of the hypotheses for undescended testis is it says that the testis has not descended because it is histologically actually it is dysplastic. That is why it is not descended. So the risk of malignancy is already there. So and orchidopexy, doing an orchidopexy does not reduce the risk of malignancy.
Can we know the percentage of the malignancies in intra-abdominal versus in the collateral also develop and testis go process for the gangrene, then what we do?
There is no way of knowing whether it is going to develop collaterals or not. That is why microvascular transplantation was developed in the first place, because the problem of founder Stephen orchidopexy was that because the collateral the pattern of developing collaterals was not consistent in all populations. So that is why they were not sure whether it is the collateral is going to develop or not, whether it is the testis is going to survive or not. They didn't know. That is why when you weigh the risk of losing a testis in founder Stephen orchidopexy versus not losing, that is why that orthotransplantation was developed as a procedure.
Meaning of undescended means, it's a not descended.
Yes, sir.
But this is a descended means. This is not a complication, not exactly undescended testis. So that's a malposition of the artery. How can we label this as undescended testis?
If it is a secondary testis or an acquired condition, then we cannot say actually it is an undescended testis, because it has already descended and now it has risen up. So maybe it is an exercise in semantics. Once or reduce the risk of malignancy, but now you have a testis that you can palpate and you can examine, and even the child can do it, because once he grows up to be 4 or 5 or 6 or 10 years of age, the malignancy doesn't develop quite early, right? So by that time he will be able to know the change in consistency or the change in size of a palpable testis. That is the advantage that orchidopexy gives. One, in regard to the risk of malignancy, but there are other indications of doing an orchidopexy as well. It increases the fertility and all those things. But then, as regards to risk of malignancy, The advantage of doing an orchidopexy is to allow for examination of the testis and to know that there is changes in the size and consistency of the testis quite early in the process.
When you bring it down, not only one reason, the other reason is to promote the spermatogenesis.
Yes, fertility.
That's very important. So bringing this testis in the early as 1 year is really not inhibit the spermatogenesis. That's the whole purpose, whole exercise.
Yes.
And also for adults, the testis, right? Which makes cyclopacy. It's don't know what percentage is malignancy, about 10-20%. And understand that it's very